I'm Ken Yamaguchi, if I haven't had a chance to meet you all. I think I've met most of you here. And on behalf of the Shoulder and Elbow Service, I'd like to welcome all of you here to your presentation on our rotator cuff research. We are very, very appreciative that all of you are here and for all the time and sacrifice you've had in our project. I hope you're going to find out some new things here today, and I hope you're going to also feel inspired like we do that the things that we are trying to do collectively as a group here are making a difference for people. And this has been a long-running project of about 15 years or so, and it's really been quite a journey. First of all, I'd like to just introduce some of the real important principles in this research project. There are several of us that have been very deeply involved in the research side from an administrative and leadership role from the beginning. First person I'd like to introduce is Dr. Sherry Teefee. She is, Sherry, if you could turn around. You could even stand up, Sherry. Sherry is formerly the chief of the ultrasound service at the Mallinckrodt Institute of Radiology. She is a professor there, and she is literally one of the top people in her field in the entire world. And we are very, very blessed to have her as part of, she is a principal investigator in this project. And the next one is her senior partner, Dr. Bill Middleton. Bill, if you could stand up there. Bill is also a former chief of that service and is nationally and internationally famous for what he does. And those two are among the very best at what they do. So when you're having these ultrasounds done and measurements taken, you're in the hands of literally the best in the world. And we are very indebted to their leadership role and their role right from the very beginning of this project. And the next person I'd like to introduce is Dr. Jay Keener. Jay, if you could stand up, I think most of you. Jay is also a principal investigator on this research project, and at a very young stage, he's one of the top and most productive shoulder and elbow surgeons in the country. And it's a real pleasure to work with somebody like that, too. Of course, the two most important people in the project are Georgia Stobbs and Rebecca Patton. Is Georgia in the room yet? Is she still schmoozing outside? But they were the glue that really made this project work, and I have no illusions. I know that all of you are here not to hear me, but because you got an invitation from Georgia. And we are very, very indebted to her, too. So I hope to convey a message that what we are doing here is very important, and that it all happened 100% because of your involvement and your dedication and your return every year, and we know it's a timely exercise to come back. So the first thing I'd like to do is, from the shoulder service, really extend a very big thank you to all of you. And this is a picture from one of the highlights of our shoulder service through the years. This is Georgia's wedding. I don't know if there's been a more beautiful bride ever, but there she is. Again, she's the centerpiece of our team, and of course probably in your lives too. And we cannot tell you enough how much gratitude we have for all of your participation in this project. All of us are here to try to make a difference in people's lives who have shoulder pain. And I hope to tell you about how important that difference is. And it doesn't happen without the volunteer participation by all of you. So thank you again. So, shoulder pain. Why is shoulder pain so important? Well, it is the second or third, if you have a musculoskeletal problem, a muscle problem, a bone problem, etc., it is the second or third most common reason why a person will see a physician now in the United States. And medicine is undergoing a really big change. It's not now life or death issues so much in the 70s and 80s. As some of you know, it's really more about quality of life issues. People are living longer, for sure, But not only are people living longer, but they're being active and enjoying the things that they normally did when they're younger at an older age. And being able to use your joints is a big part of that. And in fact, the last decade has been called the bone and joint decade because of that. The issues that were so predominant in medicine before, like heart disease and cancer and stuff, are somewhat controlled and a little bit more minimized now. And we're thinking more about how do we keep that quality of life going as you get older. And we have high activity expectations because of that. And so shoulder and other issues like a knee and back are becoming more and more important. And shoulder is one of the most important problems in the United States in terms of medical issues. Nearly all people at some point of time will have a problem in their shoulder. And if you've been lucky enough not to have a shoulder problem, then you'll know somebody very close to you who has had a shoulder problem. That's almost certainly the case. And the only thing that actually ranks higher than shoulder, perhaps, is lower back pain, which is another phenomenon that pretty much is hard to escape. So this is something that will touch all of us at one point in our lives, or at least somebody close to us at the very least. And so it is a very relevant and very, very important problem for all of us to consider. Among the things that cause shoulder pain, the rotator cuff is by far the most important. It accounts for the large majority of those things that cause shoulder pain. How many people have shoulder rotator cuff tears? I'll discuss this in a second, but about 17 million people in the United States roughly have rotator cuff tears and are at risk for a problem. I know I met one of you out there, out in the audience today, Bill, and I mentioned one of these numbers, and he said, geez, I thought I was unique. I thought I was special. Well, fortunately, unfortunately, it's not the case. There's about 17 million people with tears, and that doesn't even include the number of people who don't have tears that have pain from the rotator cuff. So this is a huge issue, and one of the things that we need to know is how many of those 17 million people can develop a problem over time, because luckily, most of the people who have these tears actually do not have a problem and can expect to be living their entire life without an issue where you're going to have to see me with a green gown on in the operating room. So I know most of you people have some form of this, and you might be thinking, oh my gosh, does that mean that we're going to see Dr. Keener or Dr. Yamaguchi or Dr. Gallitz or Dr. Chamberlain in the office for this? And the answer is most of you no. But it does account for about 2 million office visits in the United States a year and 600,000 surgeries. That's a lot of surgeries per year. And it is the most common source of a work-related pain. So this, again, is a really important issue, and that's why the researchers are so dedicated trying to find more answers about this problem. Rotator cuff disease is age-related, so as we get older, the chances of having a rotator cuff tear get higher and higher. And like I just said, our population is getting older and older. So as much of a problem as it is today in the United States, it's actually going to become more of a problem as we live longer and longer. This is the results from a study that we had done in this institution a long time ago, looking at almost 500 consecutive people that had rotator or actually presented with shoulder pain. And we looked at the average age of people as a relationship to what was the matter with their shoulder. And so the average age of somebody without a tear was about 49 years old. The average age of somebody with a tear in one shoulder was about 59 years old, and the average age of somebody with tears in both shoulders about 68. So there's almost like a 10-year even distribution as you get older on your chances of getting a rotator cuff tear. And basically, we've done other studies looking at the general population about how many people have tears. And around 50% of people over the age of 70 have tears. So how did I come up with that number of 17 million? Well, you just look at the number of people over the age of 70 and you divide it by a half, and that's how many people have rotator cuff tears. Not all of them are complete tears, but these are people with tears of one sort or another. So yes, you're not exactly a unique people, or at least unique in relationship to your shoulder. It's just a very, very common phenomenon, and that's, again, why it's so important. It is so important that this issue has been recognized by the National Institutes of Health. This research project is being funded by the National Institutes of Health, or it's usually referred to as the NIH. The National Institutes of Health is the largest governing body that provides money for research in this country. It's highly competitive. Every single researcher, whether you're in medicine or surgery or whatever discipline within medicine that is doing research, dreams of having money coming in to support their research from the NIH. It's very, very competitive to get an award from the NIH, and they want to give that money to the most worthy projects, the ones that are going to make the biggest difference for our society in the future. The highest level of the NIH grants is called an R01 grant. And basically, these are grants that actually have no limit to the amount of money that the government will give you. As long as you can justify that it is worthy and you justify that the amount of money you need is necessary to get the job done, the government will try to provide the money for this. We were actually a recipient of this NIH R01 grant about 8 years ago. And at that time, it was one of only 2 or 3 what we call clinical orthopedic grants in the entire country. That is a grant that's aimed specifically at patients and their outcomes rather than basic laboratory type of research. So this is something that was recognized by the NIH to be a very important area to invest money on research. And we've actually been able to get a competitive renewal from that also, which is a very difficult thing to do. That recognizes not only that it's ongoing importance, but that we've been able to accomplish our goals along the way and represent a good investment to the government and to the NIH. So over this time period of a 10-year grant, we've been awarded $3.75 million. Unfortunately, none of that comes to my pocket, if you're wondering. That money is what's necessary to help the research institution, Washington University, help function. It pays for all these ultrasounds, which are not cheap. Dr. Teefee and Dr. Middleton donate a lot of their time, but it's still very expensive. It pays for x-rays. Very importantly, it'll help pay for the salaries and support of Georgia and Rebecca. Part of it, there's a small amount of salary support that comes to Dr. Teefee, Middleton, Dr. Keener, and I, and we actually feel strongly enough about the project that we've donated that salary support for the most part back into the research project. So this is something that's been a very large investment by the government, and hopefully you'll see that it's been a worthy investment. So this is, again, very, very important and a very, very relevant topic to us. It's not so surprising. There's even comics about this where Snoopy says to this cactus, well, obviously I'm not a doctor, but I'll bet you anything it's your rotator cuff. And Snoopy is not too far off, because if you say it's your rotator cuff, it generally is. So what is the rotator cuff? What would Snoopy say is the rotator cuff? And I thought I'd just give a little basics on the anatomy. Well, the rotator cuff is a group of muscles that surround the ball of the shoulder joint and basically just holds that ball in the socket. It's very, very important for the shoulder because of the unique way the shoulder is built. The shoulder has motion that you can do like this that's not like any other joint. Imagine doing this with your hip, you know? So there's a lot of mobility in the shoulder. The hip is designed kind of like a ball and a cup, where the cup surrounds the ball and holds it in place. But the shoulder, on the other hand, looks more like a ball and a flat dinner plate. This is an x-ray of the shoulder, and basically the ball of the shoulder joint is right here, and the cup is just this little thing like that. It's kind of like a little dinner plate, and the dinner plate really doesn't hold that ball in place very well. I don't know, can you see that okay? But anyways, this is an x-ray of the shoulder, and that ball and socket is very analogous to this situation, like a golf ball and a golf tee, where the golf tee is pretty small compared to the golf ball, and it can't hold that ball in place very well. So instead of a wall bone to hold the ball in place, the shoulder has a cuff of muscle that kind of just surrounds that ball and holds onto it like you're holding a ball for throwing a baseball. And it's very, very important for holding that ball in place. When you get tears in these muscles, the ball tends to move around a little bit more than it should, and that's probably one of the reasons why we have pain. And that's because the function of that cuff is decreased. And that's what these cuff of muscle comes around. That's why it's called a cuff, a rotator cuff, because it's a cuff of muscles around that ball. And these things have to work very, very hard throughout our whole lifetime, and for some of us, they poop out. So these muscles come from our shoulder blade, and this is a description of that. So basically, these muscles come along. This is the inside of the shoulder blade. This is out towards your arm here, and these muscles just come out like that and form this cuff out here. And this is an MRI. You probably have seen MRIs of your shoulders and stuff, and this is why the MRI looks like that. These muscles come out like this from the middle of your body towards the outside, and here's the same thing. And this is an example of a rotator cuff that's intact. This is a normal rotator cuff coming all the way around your ball and attaching out here on the outside of your ball. And that's what it should look like most of the time. Unfortunately for a lot of people, as we get older, it doesn't quite look like that. This is a depiction of a tear. I'm sorry, this is a little bit blurry, but there's a little hole here in the cuff here, and you could see this would look like on MRI kind of like this. This muscle should have came like this all the way to here and attached right there, but in this case it's popped off. And this is a MRI from a very small tear. The muscle should have attached here and it's just moved to here. An example of a large tear is a muscle go all the way back here. And this is an example of a relatively healthy muscle where it's very big and just fills this entire space here. A bad muscle belly would just be a little sliver back here. So that's what a rotator cuff kind of looks like to us when we diagnose it, and that's what the anatomy is like. So the rotator cuff tears are an important, really important medical problem in the United States. And before we started this project, it was actually really surprising that we didn't know much about the natural history of the rotator cuff. Given how important this is in the United States, it's just shocking that we didn't know what the natural history is. What do we mean by the natural history? It means that we could answer this question: what happens to this rotator cuff if it is not treated? Okay? Because if we don't know what happens without treatment, we don't know whether treatment can help. And we don't know whether treatment is the right thing to do. So for instance, if you have a tear and it doesn't cause you pain and you're strong enough and you're going to be like that the rest of your life, why would you want an operation? But if you knew that tear is going to get bad, worse and worse and worse, and you're going to lose your ability to use your arm, well then you'd want an operation to prevent that from happening, right? Well, when we started this project, we really didn't know the answer. We didn't know whether or not these things tend to get bad in time, what were some of the factors that might lead to that, and etc. And these are just absolutely critical things to know, just fundamental things to know, and able to counsel people when you should have surgery, how fast you should have surgery, whether you can wait, what other alternative treatments are possible for this. So it was just a really fundamental void in our understanding of rotator cuff. And the consequences of that was that in the United States and around the world, the treatment was not standardized. In other words, you can go to one doctor down the street and they may say, you need surgery, and you could go to another one and they say, no, definitely wait and have a shot in your shoulder instead. You can go to a different part of the world and they would use one type of treatment versus another. And there was just a lot of uncertainty about how to treat rotator cuff tears. At the end of the day, we didn't know who to maximize conservative care with. In other words, who should avoid a surgery and try things like therapy and injections and stuff like that. And we didn't know when we should say, yes, you should have surgery and you should have it soon rather than waiting before something bad happens. We just didn't know the answer. And these are critical things. At the end of the day, we have very fancy ways to take care of people, but if we don't know when to use them correctly, then that can really negate what we should do. And at the time that we were doing this study, at the very beginning, there was actually this publication, the Journal of Bone and Joint Surgery that we demark as JBJS here. That is the leading publication for orthopedics in the world. This is our gold standard for publications, and usually the best articles are in JBJS. And this article outlined that there was a lot of variations in the way orthopedic surgeons viewed rotator cuff disease and a lot of variability in opinions about who should have treatment versus not have treatment. So at the end of the day, we wanted to answer some questions. Is early treatment better for some people? Is surgery better treatment? Is surgery sometimes the best treatment for them? And should surgery be avoided in other people? And so these are fundamental things that we were trying to answer, and these are fundamental questions that all of you have helped us with. So there are some known risks that can happen if you have a rotator cuff tear. Okay? If you have a rotator cuff tear and you don't get treatment, these are some of the possibilities that can happen. I'm not saying they do happen, but these are some of the things that we are afraid of. The tear can get larger, it can get bigger and bigger. The tendon, which is the part of the muscle that attaches to the bone, can get weaker and weaker, so that if you're going to have treatment later, it's hard to hold a suture. The muscle gets smaller and smaller. It's a process that we call atrophy. The muscle can turn into fat, which is a process called getting older for one, but which is called fatty degeneration. And then arthritis, which is development of degenerative changes where you get towards bone on bone. So these are all things that can happen with a rotator cuff tear over time. And one of the questions we had is what is the probability of these things happening? So here's kind of a depiction of the situation. What if this is a young person, and I consider young 50 years old, and basically this is a small tear. This is the end of the tendon. It should have been connected here. This is a nice, healthy muscle belly here, okay? And if you say, no, you don't need surgery on this and you're 50 years old, then you have to answer the question, can it just stay like this for a long period of time, hopefully forever, and not get worse, okay? Because one of the risks that you can have is maybe you treat this person without surgery and you do therapy, maybe an injection, and the pain will go away and the patient will feel great, and they go away from your office, and then all of a sudden, 10 years later, they come back and go, doctor, my shoulder really hurts again, and now I feel really weak, and you get another MRI, and it looks like this. Now the tendon that used to be somewhere around here, see this tendon's right here, is now all the way back here, and there's nothing covering the ball anywhere. This muscle is really tiny now. It used to be nice, big, thick muscle like this. So now, when you have this situation and the person's older, there's be a very significant limit to what we can do to help them. We could have helped them a lot when they were younger and with a smaller tear. And the question is, how can we avoid something like this from happening? So these are some of the really important questions that we are trying to answer with this study. Another major issue that we've discovered with some of our research here is that as you get older and as these tears get bigger, they don't heal as well if you have surgery. So if you have surgery at a later time period, they don't tend to do as well. We've done 5 different studies on these, looking at different aspects of healing. And basically, the one thing that seemed to be common among all these studies is the average age of somebody who healed was about 55 years old, and the average age of somebody who did not heal was about 63 years old. So as you get older, the benefits of surgery start to drop. And these are things that we need to keep in mind in counseling people about these surgeries. So, why do we not know about the natural history of rotator cuff disease? Why don't we know more about such an important topic? Well, in the United States, if you have a lot of shoulder pain, usually this natural history is going to be interrupted by treatment, and often that treatment is surgery. You can't tell somebody with a really severe pain in their shoulder, they can't sleep, they can't use their arm very well, you probably need surgery, but let's not do surgery so Dr. Yamaguchi and others can do a natural history study on you. Okay, so that's, for the big part, this is a problem with all orthopedic diseases, or a lot of diseases in all of medicine, is that we need to treat people, so we don't know really what happens if we don't treat people. So what happened and what's been unique about this study is that it has always been known for about 50 years a population of people that have complete tears of the rotator cuff, and they have no pain, and they have pretty much normal function for their age. And these are people with painless tears that we call the asymptomatic rotator cuff tear. Now, this is a potentially great way to look at natural history. Why? Because they don't have pain, so they don't need treatment, so we can find out what happens to them over time. And that's why all of you are here. This is the unique population for study. And this has been the big advantage here at WashU. So we thought that this type of population, people like all of you that had rotator cuff tear but no pain, would be a model for natural history studies. In other words, a model being a representative population that help us understand about a painful population, because you are a representative population. What happens with all of you is going to be very similar to people with pain. So it would be a model for us to study why some tears hurt and others don't, how common are these tears, and what is the risk that they will become worse if you don't treat them early. That is one of the main fundamental questions. What is the risk that these will get worse and worse over time? Our first study that we ever did was this one. It was a small pilot study. It was done in 2001, so 12 years ago. That means that's when it was published, actually. So it was really done about 14 years ago or so. And this was the thing that kind of got us kicked off here. I was really, really fortunate when I first came here. I came here in 1995, and basically I was in one of my early days, and after starting here, I ran into Dr. Bill Middleton in the elevator, and he introduced himself and said, "Hey, do you know that we do shoulder ultrasound at Washington University?" And my first response was, "What's that?" Because the gold standard in the United States is really using an MRI. And this was really one of the only 1 or 2 centers that was doing shoulder ultrasound. And not only that, this was the best center for that. Basically, he introduced me to this imaging modality. And I went down and actually had my shoulder imaged by Dr. Middleton that same day or very soon thereafter. And was really amazed by the pictures that he was able to generate of my own shoulder. At that time, I learned that the radiology group here, Dr. Teefee and Middleton, routinely did ultrasounds on both shoulders. So basically, when you came in and said, "Oh, I have a really painful right shoulder," they would do an ultrasound of that right shoulder. And I understand we use really cold gel that's now warm gel. But they would do an ultrasound of that right shoulder, but they would also do an ultrasound of the left shoulder. Now, why would they do an ultrasound of the left shoulder? Well, because it was a brand new way of looking at the shoulder, and they wanted to look at the normal shoulder to compare it to the abnormal shoulder. Well, along the way, they actually saw a lot of abnormal shoulders in the shoulder that didn't hurt. And one of the things when I saw that was I asked Dr. Middleton, "Do you see a lot of tears on the other side?" And he said, "Yeah, we actually do." And based on previous knowledge about these asymptomatic tears, we predicted that there would be a large number of rotator cuff tears that they were actually catching by accident on the other side, and these are asymptomatic, painless tears that could potentially be the source of a new study, a different kind of study that's ever been done in the United States. So again, we were really excited because this represented a unique study opportunity. Now, one of the problems we had at the beginning of the study is that we were using ultrasound, and ultrasound was not very well known. In fact, there was a lot of skepticism about the accuracy of ultrasound around 1995. The last article was in JBJS in '86 that showed only 60% accuracy. So one of the first things that we did, Dr. Teefee and Dr. Middleton and the shoulder group, was to try to see exactly how accurate this thing is. Because if we're going to use this for a major research study, we better make sure that our measurement tool is very good. And over time, these two people, who are, again, literally pioneers in this subject and among the very best in the world at it, showed us that this is a very, very accurate imaging modality. Most people think of the MRI as the way to look at the cuff. I have learned that pretty much the ultrasound is a much more accurate imaging modality, and it's a little bit better tolerated too. So this is an article that we published, and this was now 13 years ago in the Journal of Bone and Joint Surgery that showed how accurate this imaging modality was in looking at the rotator cuff. And since then, we've had a multitude of other articles looking at the accuracy in various different situations, including looking at the fat content and how small these muscles get over time. If you notice, all of these articles are in the journal Bone and Joint Surgery, which is not an easy thing to do. For a typical academic orthopedic surgeon, they'll probably go through their career with 5 or less of these articles. And the majority, you'll see Dr. Keener's going to talk about our results, but you'll see that the majority, almost all of our articles related to this project have been in the Journal of Bone and Joint Surgery, which speaks to our emphasis on quality of the research. So this has generated this NIH study. Our goal at the beginning was to have about 300 total people in the study. Not all of them have rotator cuff tears. Not all of them have complete tears. Some of them had partial tears, some had complete tears, and some of them had no tears and served as a comparison group for this. And our goal was to follow them for up to a 10-year period. I met some of you out here that are out at about 10 years or even longer. In participation in this, and check for things like tear progression and what are some of the personal characteristics of all of you that might lead to one issue over another, or no issues related to your rotator cuff. Our study is one where these are things that are going to be very familiar to you. There's yearly exams and long questionnaires, I'm sorry about, that you have to fill out. And these are all information that we kind of gather to find out what makes you as individuals different from others that may have pain and other issues with the rotator cuff. You guys get ultrasounds. Again, they're very accurate tests. And x-rays to look and see whether the ball is moving too much. We have a constant check of the data and information. Just to give you a flavor for some of the quality control that we have, when you come in and get your exam, you'll get either Georgia or Rebecca examining you. Once you have your exam, they write out the exam features on a paper. Then, if Georgia examined you, Rebecca then checks Georgia's results. Following that, the paper is sent to data entry people. These are people that enter these results into a computer. And they enter these things into a computer 2 or 3 times. I forgot how many. But they enter it multiple times. And basically, what has to happen is both of the sheets, all 2 or 3 of these sheets have to look exactly the same. That ensures that the data is entered into the computer correctly. Once the data is entered into the computer, we now have a statistician, Karen Steger-May, who's been instrumental in this study, check the data for any outliers. She'll do a statistical analysis on the data to make sure that there's nothing that was inputted wrong. So sometimes, a 7 can look like a 9, for instance. And they could be put in that way, and it could be wrong, and then a decimal point might be moved or something like that, and these things are checked. And once that is done, then this data is protected by Karen Steger-May, and then we are only gained access to do it for study purposes through her, and then more statistical analysis performed. So this data is very tightly controlled. It is kept private. And we try to make sure that we have the most accurate information possible. So then we ask, has anything changed from year to year? Is there new pain? Is there an increase in the size of the tear? Is there an x-ray change, strength change? There's all kinds of questions we could then ask of this data, and that has been the source of the information that Dr. Keener will present to you. So what are some of the accomplishments? I'm not going to talk about the specific data, which is what Dr. Keener will do. Well, one of the things that I think is pretty neat is our research on the natural history of rotator cuff disease has stimulated other research on natural history by other investigators in the United States and around the world. They say that imitation is the best form of flattery. And so the fact that we started this type of research and others are now finding it important to do at major centers means that it is, again, a critical thing for our field. Because of the things that we published on ultrasound has now become a very, very common thing, a common way that people are using to look at the rotator cuff. It's a 10, 15-minute exam as opposed to being in a small tube for 45 minutes to an hour. It's an exam that costs about a couple $100 versus an MRI that costs $1,000 plus, and it's really been a neat thing to see that Dr. Teefy and Middleton's work has really caught on around the United States. It's given us a lot of insights on why the disease and how rotator cuff disease progresses over time, and Dr. Keener will talk about that. And it's generated more new research questions that we never even thought of at the time we first started in this project. There's been multiple publications, and nearly, again, all of them have been in JBJS, which is really a wonderful standard to have. Our findings are highly quoted by physicians and used to dictate treatment. We entered into this project to make a meaningful, real, and tangible difference for people's lives. And it wasn't just to get publications and fame and fortune. We really wanted to, we're a very dedicated group of people, and we really wanted to make a difference. So one of the great things is that our research has been recognized by a lot of people, and it is changing the way people think about rotator cuff disease. And there have been improvements in the way we treat people, including improvements in surgery based on some of the findings that we have. So it's been very gratifying from that standpoint. Probably one of our most important accomplishments in this study, though, is that we received a renewal from NIH, and that has kept Georgia and Rebecca employed. So. And believe me, that's important because they're not cheap. So there's a lot of more shoulder work ahead. This is the shoulder group at Washington University. Dr. Gallett's there on your right, and Keener below, and then we have a new person, Dr. Aaron Chamberlain. And this is just a really neat team, and a team of caregiving staff with us, including Georgia and Becca. Meredith Moore, you met at the entrance desk too. Gene Szerzinski. There's just a group of people, Cheryl Wabi, that are all involved in patient care and outreach that are very, very important for all of us to not only do these type of research studies, but to provide the best care we can whenever that's unfortunately necessary. So again, on behalf of our service, thank you so much. Jay Keener will be next on talking about our research accomplishments. Thank you.